Good afternoon, and welcome to this edition of Caregiver's Corner, which is made possible through an educational grant from Lundbeck. Today, we welcome Mary Edmondson, a clinical associate in psychiatry at Duke University and president of the North Carolina Center for the Care of HD in Raleigh. If you attended the HDSA convention this year, you may have attended one of the workshops Dr. Edmondson conducted on the psychiatric management of HD. Today, she will be talking about managing behavior in Huntington's disease. But before I hand the webinar over to Dr. Edmondson, I'd like to take a moment to review how you can ask a question and how to view this webinar again. Questions will be answered after the presentation. However, you may send a question anytime during the presentation. To send a question, go to the control panel that appears on the right side of your screen. There'll be a panel there.
The broadcast is now starting. All attendees are in listen-only mode.
There'll be a panel for typing in a question. After you've typed your question, please hit the send button. You can send as many questions as you like, and we'll be sending the questions on to Mary during the final 15 minutes of this session. To view this webinar again, you'll need to wait about 24 to 48 hours and then go to the HDSA national website. Scroll down the home page until you come to the link for this webinar. There'll be an accompanying PowerPoint presentation that will allow you to print the slides out, as well as a PDF that Mary has provided that will have additional information and resources for you to use. Older webinars are archived in the Living with HD section. So now it's with great pleasure that I introduce Dr. Mary Edmondson and Caregiver's Corner. Mary?
Thanks so much. It's a pleasure and an honor to be able to talk with people around the country today. I'm having a little trouble advancing my slides, so do I have control of that here, or do you guys still have control of that?
No, you have control of it.
Okay, let's see if we'll manage to go through. Just a couple brief comments before we get started. That is that I'm one of the speakers for Lundbeck Pharmaceuticals, just so that you know. The second is that the information that I'm going to provide to you today is for your information, and I really would suggest that you talk over the things that I'm going to discuss with you today with your private physician, the person who is most capable of evaluating all the problems that you may be having and help you create an individualized treatment plan. So it's true that I'm a psychiatrist. I'm also an internist. I've worked with Huntington's families since the early 1980s, but my real claim to fame is this gentleman who was a person who developed Huntington's in midlife, and over the 25 years of his illness, I was honored to watch him handle it with great dignity, and most of everything, the basis of everything that I've learned about Huntington's was related to this gentleman who happens to be my father. So in 1980, there were two things that we were given for the treatment of symptoms, and that was Haldol and Ativan. And things, this is now, 30 years later, and it's my belief that there's a whole lot more that can be done for Huntington's today than there was 30 years ago. And I think part of that is because we have a much better understanding of which symptoms of Huntington's are responsive to interventions. The work related to this continues to be ongoing, and we don't have as good a data as we'd really like to have. We have a good sense that there are symptoms that get a whole lot better with medication management. So that's one reason. The second is that there have been drugs that have been developed for a variety of illnesses related to Huntington's, like schizophrenia and bipolar disorder. Those disorders drove the development of much better medications than Haldol and some of the older antipsychotics and older drugs. And so not only is there a better understanding of which symptoms are responsive, we also have better drugs to treat them. So one of the questions that I'm asked all the time is, well, I'm looking for a psychiatrist. What kind of psychiatrist do I need? Well, there's a lot of good psychiatrists out there, but neuropsychiatrists and geropsychiatrists have specific training in psychiatric disorders that sit on that edge between sort of neurology and psychiatry. So if you wanted to look for someone who had some special expertise they might be able to offer, that would be the type of psychiatrist to look for. One of my big areas of interest, however, are non-medication interventions that can change behavior. If you look at a variety of psychiatric illnesses, schizophrenia, bipolar disorder, depression, anxiety disorders, many others, the non-pharmacologic treatments or psychotherapeutic interventions often are as useful as medications, and non-medication interventions obviously don't have side effects. So I always think that trying those are preferred before you begin medications. Unfortunately, there's not much data at all about any of these, but there's a lot of personal information that I've gained from my family and from others about their effectiveness. So before we start talking about those interventions, I would like to start off with talking about the idea of empathy. So Heinz Kohut is a big writer in psychology, and he defined empathy as the capacity to think and feel oneself in the inner life of another person. But this is very challenging in Huntington's, because how do you, with your completely intact brain, think like somebody who has Huntington's? It's, one, really difficult to understand the functions that people normally have, much less how you think without having functions. So it's pretty complicated to figure out what it's like to live with Huntington's disease that way. And I think the basis of sort of attacking this problem is to understand that all human behavior, all of it, no matter how good, bad, or indifferent, is on some level rational. On some level it's explainable based on either somebody's personality or their previous experiences, the stress that they're under at the moment, or their underlying disease process. And so I'd like to spend a few minutes talking about the underlying disease process in Huntington's. So there's one particular part of the brain that when we talk about Huntington's, we don't talk about probably enough. Everybody talks about the caudate nucleus degenerating and the motor symptoms of Huntington's, but what we don't talk as much about are the projections of the caudate nucleus, the sort of traffic that comes out of the caudate nucleus and where it goes. And so the place that it goes to is some place called the prefrontal cortex. And it's the newest part of the human brain, is the prefrontal cortex. And one way that I like to think about it is that it's actually a simulator, just like an airline pilot gets into a simulator to learn how to fly a plane properly and to anticipate problems. Your prefrontal cortex provides a very similar function to you. So it allows you to create a vision of what the future might be like based on whatever choices that you make. So if you decide you're going to marry one guy, you would have this kind of life. If you decided to marry another guy, you'd have this different kind of life. And so it allows you to envision those two different sets of choices and what the consequences of them would be. So an integral part of pursuing a goal is to understand the sequences by which you get there. And so the other thing that the prefrontal cortex does is it allows you to plan and initiate and sequence tasks. So in the process of performing that task, it's important to keep your mind focused on where you're going and how you're going to get there. So it's important to be able to not pay attention to things that are not important to the pursuit of your goal. So it also stops the flow of unimportant information into your consciousness. And then finally, in the pursuit of your goal, if something changes, if something happens, there's a thunderstorm, the door slams, the road you're trying to get on requires a detour, you need to be able to organize a change in your behavior when there's a change in the environment. And that is a major source of problems in Huntington's, that the flexibility that the prefrontal cortex allows you to have, as it becomes damaged, people become less ability to organize a flexible change in their actions. So the other thing that the prefrontal cortex does, I like to think of it as sort of a social secretary, in that your prefrontal cortex casts a social hue over everything that you choose to do. So it recognizes social cues, it recognizes facial expressions, it recognizes the prosody of speech. I mean, everybody knows that you can say the exact same statement and it mean entirely different things based on how you put inflections or how you change the tone of your voice. And so all of those functions reside in the prefrontal cortex. Again, it stops the flow of unimportant information into your consciousness. If you get words that don't match with nonverbal behavior, it helps you to distinguish which of those two you want to pay attention to. And finally, it controls the expression of your behavior. So there are some circumstances in which it's important to inhibit your ideas or your impulses to act in a certain way. And at other times, it's important to be activated, to be able to act on what it is you need to do. And so an abnormality in this component of the prefrontal cortex can either cause irritability or it can cause apathy. Finally, the prefrontal cortex manages mood. So mood is an emotional state of mind that affects many domains of your experience. So it's not only that the clouds are gray and your job's not going well, but your husband also hates you. I mean, across multiple domains of your life. It lasts for days or months. It can either be an increased mood or it can be a depressed mood. And all of that is managed inside your prefrontal cortex. So this is my simulation of what it would be like to live with Huntington's. And I don't know for sure, but this is the best that I can come up with based on what I've seen my family go through and based on what my patients have told me. So this component of it relates to mood. I feel useless, like my life is over. I can't trust myself anymore. Everything bad that happens is my fault, and people would be much better off if I was gone. I'm perplexed by how others react to me and don't really understand their reactions at all. I blurt out unkind and rude comments even if I hurt the people I care about. I can't read emotions, or sometimes I misread the emotions on the faces of other people. I can't get started with anything anymore. I do everything slower than I used to do. The links between steps are missing. I sometimes can't figure out what I need to pay attention to, and then I feel overwhelmed. So my question is, if you had Huntington's disease, could you watch all these channels at once? So think about it. You've got your personal history, you've got family, you've got your daily life with geography and food, you have an underlying biology that's like a moving target at all times, and one day you can do something and the next day that you can't. There are things that you used to be able to do that you can't anymore, like travel or play golf or play sports. So how in the middle of all of that do you end up saying yes to your life and yes to your future? Well, I think the bottom line is that I think having Huntington's disease is really hard work. It's more work than I think I could humanly imagine. And I know that the vast majority of people, or everybody that takes care of somebody with Huntington's disease, works very, very hard. And I think that if you're taking care of somebody who just appears to be sitting around like a lump on the log, or they're making everyone else's life more difficult, I think what's hard to remember sometimes is that they work really, really hard to just simply get through their day. So what are some behaviors that are fairly typical of Huntington's? So irritability is a big one. We're going to spend a fair amount of time talking about irritability and impulsivity, perseveration, unawareness, denial, refusing treatment, problems making decisions, and dangerous behavior. So just like the whole idea of having Huntington's means that you have to work really hard. I think this is another one of those big phrases to kind of keep in your head, and that is that you need to expend more effort making things go right than correcting things that are going wrong. And if you're interested in reading more about this concept, the Anatomy of Peace, a book written by the Arbiter Institute, does a wonderful job of helping people think through this whole concept. So in order to make things go right, you need a toolbox of things, tricks of the trade, different ways that you can manage things. And so we're going to talk about each of these different things, and we're going to talk about them in the context of specific behaviors, but any of them can be tried for any other symptom. So even if I talk about one technique with irritability, it doesn't mean that it's not going to work for perseveration. So just kind of keep that in mind. Some general factors that affect behavior. One is stage of disease. People are going to have different types of symptoms at different stages of disease. And I can't tell you with certainty exactly what symptom comes after what symptom comes after what symptom, because I don't think that we know that yet. But we do know that people have more severe behavioral problems when they're in mid-stage, stage 3 Huntington's than they do potentially earlier in their life. And people who in the earliest stages of Huntington's may have completely different symptoms than they do when they're in the latter stages of their disease. So you got to keep that in mind. Stage of acceptance. So with every loss comes a process of acceptance that involves lots of things: denial, anger, bargaining, all the stuff that has previously been written about death. And so every loss that someone has, they go through each one of those stages. And so you have to keep that in mind too when you're considering someone's behavior. Awareness of symptoms. We're going to talk about this a little bit more, but people with Huntington's don't always have awareness that they have symptoms. Someone's ability to communicate verbally makes a big difference. Their emotional state. I mean, there are days I get up that I'm anxious. There are days that I wake up in a bad mood. That's no different than somebody who has Huntington's. And then the other thing that I think sometimes we forget are health factors like hunger and fatigue, thirst, discomfort, or intercurrent medical illnesses or injuries. So we're going to talk about irritability because it's a really important symptom. It's thought to potentially be the earliest symptom of Huntington's disease, even as much as 15 years before the onset of motor signs. It's considered a very early symptom of Huntington's. And the reason it's important to pay attention to is because of its consequences. If someone does not know they have Huntington's and they become irritable in the workplace, they become irritable with their family, there can be potential financial and occupational and social consequences. And irritability is often demonstrated most to the people who are emotionally closest to that affected individual. So either a spouse caregiver or potentially one of the kids with whom that person lives. So there's some characteristic features of irritability in Huntington's, and that is that very, very minimal or trivial triggers seem to set it off. It's not premeditated. People don't make plans to have these explosive episodes. It serves no purpose. There's no real gain to be made with this behavior. So it's not manipulative. There's almost no buildup. So somebody goes from 0 to 60 miles an hour in mere seconds. People know that this is behavior that's not typical of them, and it's not behavior that they choose to do. And so afterwards, the person with Huntington's may be embarrassed or very apologetic after the episode. And it often is a harbinger of a new stage of decline. So if one day you're able to do something and over the course of a couple of weeks it becomes more and more difficult to do that task to the point where it's impossible to do that task, it's very frustrating. And if you have not a great ability to inhibit your impulses, it's going to come out as irritability. And so irritability is often a harbinger of a new stage of decline in the process of the disease. So when you go to the doctor with your loved one with Huntington's, and your loved one can actually be their absolute best self and show absolutely no irritability and be, you know, the most calm and best person ever when they're sitting there with the doctor, and you're scratching your head saying, but wait a minute, last night he almost slugged me. So it's important to know that your visit with the doctor is a snapshot. It's not a movie. And that doctor is only going to see a snapshot. They're not going to see the big picture. So unless you talk to the physician alone, you're not going to be able to communicate at times the severity of symptoms or even the frequency of symptoms. And the person that has irritability is going to be embarrassed. They're not going to necessarily want to bring it up. So it's my suggestion that you get in the habit of talking to your loved one's doctor alone. And if you start that practice early on in the course of the person's care with a physician, then it's not going to feel like, oh, well, doc, I need to talk to you alone today, and your loved one kind of puts one and one together, and they tend to get angry about it. So it's important to begin the practice of open communication as much as possible, as early as you can. So if you're standing there in the middle of one of these episodes, what can you do? Well, probably the most important thing to do is to stay calm, because the person that's standing there in front of you is not. And one of the two of you has to be calm, so it probably needs to be you. Don't fight back, don't argue, say very little, keep your voice at a very level tone of voice, and you present a calm focus for that person as they're working to control their feelings. Make your environment as safe as you can. If you're in a car, slow down or stop. If there are kids in the room and you're afraid that your loved one is going to go after the kids, you need to take them to another room. If you're in a public place, you need to get that person to someplace that's familiar and comfortable to them. If you have to redirect someone in the middle of one of these behaviors, it's often helpful to use a distracting sensory event like a loud noise or calling someone's name sharply. And then you need to have a plan in place in case you need help. You need to know you can call your neighbor. You need to know exactly how you would get crisis help to your home. Here in Wake County in North Carolina, we actually have something called CIT officers who are specially trained to deal with folks who have behavioral problems. So these are the folks that come out to somebody's house instead of the police. And I would never have known that had I'd not been told that by my social worker. So there's all kinds of things that are out there to help if you look for them sometimes. So an ounce of prevention is worth a pound of cure, and when it comes to irritability, the best way to go about fixing it is in retrospect. So you need to have a system by which you analyze what has happened. And there's lots of different ways to do it, but one of the ways to do it is to do a behavioral analysis where you write down systematically what happened. So the time to begin that analysis is at the last time that you can remember before the event, when everything was going okay and everything was pretty normal. And so then track the chronology of each event, everybody's emotions and everybody's actions, everyone that was involved. So, and it's important not to get mad at yourself or to judge your own actions or feelings, because we have automatic responses to other people's behaviors, and for you to learn how to control some of your automatic responses may take a while. So gather information. What time did it happen? Where did it happen? Was anybody else involved? What happened before or after the event? Was it a special day like a holiday or Christmas? And have there been any medication changes. So this is a sample behavioral analysis. So husband comes home from work and feeds the dog, and then he says hello to his wife. And then he immediately goes in to change his clothes. So his wife follows into the bedroom and demands that he feeds the dog. The husband sighs and explains that he's already fed the dog. But Mary says, no, you're lying. You just got home and you didn't feed the dog. He continues to change his clothes, and he turns his back for just a moment, and his wife begins to scream, says he got home, she hates him, and begins to whack away at his back and scream. So when this kind of a scenario happens, there's lots of different things going on here, and it's really important to identify what is the problem. Because there's a lot of things here that are hurtful and a lot of things that are painful, but it's important to sort through that and to get to the underlying problem. So, for example, it might be from Don's perspective that his wife telling him that she hates him is actually the most painful part of that whole scenario. But the problem may really be that irritability is what's causing all of those other things, and that is really what needs to be targeted. It's important to understand the second half of this scenario, because there are two people involved, and it might really be that, you know, the husband's really tired, he's working too hard, he's depressed, or maybe he really has been ignoring the dog and breaking his promises. In prioritizing which problems to target first, safety always trumps everything else. So these are a couple of things that I'd like to really focus on in terms of safety. One is that aggression is never acceptable. And the reason that I say that is that if people get into behavior patterns where they manage frustration in a certain way that involves aggression, then the more they do that, the more that behavior pattern is going to get ingrained and become a habit. And so it's really important that the very first time that that happens, that there needs to be an intervention of some type. Maybe there's a medication change that needs to be made. Maybe there's an environmental manipulation that needs to be made. But there needs to be something done, and it needs to be communicated to the Huntington's person that aggression is not acceptable. Weapons in the home are always risky and should be removed. Unsafe driving is like aggression. It has to be addressed. And finally, suicide is a preventable complication in Huntington's disease. Talking about it doesn't make the risk of suicide go up. It should be talking about the quality of someone's life and the quality of their importance to their family and how much they mean to you. And it should be an ongoing conversation. And if someone has feelings that their life is no longer worth living, it's just it can be a symptom as much as it can be a reaction. So once you have safety covered, then it becomes a quality of life issue. And when you consider quality of life for someone with Huntington's, then you have to take into consideration that Huntington's disease is a family disease. And each family is a complex combination of people's needs, vulnerabilities, and stressors, and everyone in that family system counts. So these are some typical quality of life problems: depression, irritability, perseveration, etc. None of those are more important than caregiver needs like fatigue and illness and a need for respite, the needs of immediate family members like children, and then needs of outside helpers. You never know. Sometimes the person that might be helping you care for a loved one may have needs that they're not describing to you. This is an important slide. These are common triggers for explosive behavior or just degeneration in behavior in general. Fatigue, hunger, dehydration, pain, change in routine is very important. And there can be very subtle changes in routine that can cause major behavioral problems. Illness, medication changes, recent loss, holidays, political events like a national election, and changes in the life of important family members like a daughter getting married and getting ready to have a baby, or a wife having a job change, that type of thing. when you decide what you think the most important goal is, and you've looked for triggers, and you have a plan in place, then the next thing to do is to set realistic goals. And in considering this, I want you to think of yourself as a surrogate prefrontal lobe for the person with Huntington's disease. So you're having to plan for them an action that will alter their behavior. And so you almost have to help them sequence and plan out anything that you're expecting that person to change. So with that in mind, when you set goals, your goals need to be important. They need to be significant. For example, one lady told me that she was all worried that her husband was pulling the sides of his eyebrows out. And although it was not necessarily physically attractive, it wasn't like the behavior itself was accelerating. It was not like it was a particularly unsafe behavior. It was just painful for her to watch. So I asked, I said, okay, how important is this for the two of you to struggle over changing this? And she finally decided, well, it's not all that important. We're not going to go make all these big changes in our life to accommodate a few eyebrow hairs. So the next thing is that you need to set goals that can be achieved. If you, back to my example about the eyebrows, if you have 3 or 4 things that you know need to be achieved, or you would like for them to be achieved, but you realize it's going to take a whole lot of time to do them, you have to decide whether or not the energy expended is worth the results. And you need to understand that the most significant change results from changes in the environment or changes in caregiver behavior, because there's no way to dial back those neurons. There's no way to get, there's no way to go to restore nerve function and brain function that is either very sick or in the process of dying. So as you're creating these plans by which you achieve goals, it takes a lot of creativity. And so one of the things I think is really helpful is to find other people who've been in your shoes before, because anybody who's cared for a Huntington's patient, even if their loved one is at a more advanced stage than your loved one, they've been where you are. And it makes them feel much better to know that they can help someone so they won't go through that stage of illness. It won't be as hard for you as it was for them. So ask. There's some online discussion groups which I think are well monitored and do a good job of helping people with their ideas and how to share ideas. You can get ideas from experienced and reliable family members, and I want to focus on the words experienced and reliable with that. You want to talk to the people that you think have been the most effective caregivers in your family. And if none of those things are available to you, you can always work with a psychotherapist. And if so, I would suggest that you work with someone who has a cognitive behavioral background. So dialectical or cognitive behavioral therapist. Another type of therapist or caregiver who may have experience and tips to offer you is somebody that's worked with individuals with traumatic brain injury. Okay, communication. Communication involves talking and it includes listening. So we're going to talk about both of those two components of communication. So actively listening so that you understand somebody who has Huntington's disease means listening more to the spoken word. So you need to attend more to how that person feels than how they act. If there is an area of conversation over which there is some disconnect and you're having that individual might be saying things you can't agree with because it's delusional or it doesn't completely match reality, it's more important to pay attention to the emotions that those things create than the content. So don't discuss content you can't agree with. Finally, talk slowly and give the person with Huntington's more time, like 2-3 times more time to absorb what you've said. A person with Huntington's thinks much slower than you do, and it just is going to take it longer to get into their head. So when you're going to communicate your plan to the person with Huntington's, you need to have a couple of tricks to help that person keep the plan foremost in their mind. So I'd suggest you get a whiteboard, one of them for daily goals and one of them for daily schedules. My experience with people that have frontal lobe disease as well as people with Huntington's is that you need to keep it really simple and you need to not overwhelm them with a huge number of daily goals. 3 to 4 is about the most that I think someone can handle. Try to include something that's fun or something that the person can look forward to. Always focus on the positive and not the negative. And realize that you may have to tell somebody something over and over and over again. So it's called broken record, where you say the same thing over and over and over again because it's just going to take longer for that person to absorb what you're talking about. So here's a couple of examples of whiteboards where you can, put up somebody's daily schedule, and close by you can set some sort of an alarm clock. If the person with Huntington's happens to be an Apple geek, you can put an iPhone and put all these to alarms so that there's constant reminders throughout the day. Oh, I've got to go do something. I have to go check my schedule. In terms of daily goals, you can mark up what your daily goals are. If there are other people involved in daily goals or a daily schedule, be sure to add their phone numbers up there as well. And if possible, if your family member can still speed dial or have the fine motor coordination to be able to utilize a handheld device, you can just program them in as well. So another thing about communicating, I don't know about most of you, but I haven't met too many people who have been able to manage Huntington's single-handedly throughout the entire course of the illness. So there's almost always more people involved than just yourself, even if it's home health aides or other family members. So the more people involved in taking care of somebody, the more communication needs to be systematized. And whatever your plan is, you need to explain what it is that you've planned to do and why you think it'll work. So, and one way to keep everybody communicating, especially with big groups, is to create a Facebook group page or a caregiving network. And there's an organization called Share the Care that's available on the internet that will offer you a bunch of forms to help you keep track of all these things. So the next symptom is perseveration, and perseveration is a repetitive emotion, thought, or action that occurs when it's no longer useful or meaningful. It occurs in people not only with Huntington's, but frontal lobe injury like stroke and Alzheimer's disease, etc. Managing perseveration often requires redirection, which is simply changing the subject, starting a new activity, doing something different. And for some people, you can actually give them symbols that it's time to stop, like you could put a key in their hand as a cue to move on. One of the symptoms that I hear a lot about, especially for people that live by themselves, is that they tend to call their family members, and they'll call 5 times or 10 times or 15 times a day. When you're in the middle of work, that can become pretty disruptive and impair your work ability. So one of the things that you can do is you can get tickets, and you can stick it in a jar, and you can say, when Mary gets 10 red tickets or blue tickets, and when her tickets are gone, you can't call anymore. If you have someone, for example, who becomes very focused on their medications, and they're agitated, and they know that they get some relief from their medications, but you really can't dose them anymore, so they're constantly asking for medications, you can write the name of the medication on a card and rip it up to symbolize that the activity is over with. Unawareness, or anagnosia, is a biological unawareness of a symptom, and again, it's often attributable to lesions in the frontal lobes. It's good because on one hand, someone's not aware of the degree of their impairment, and they're going to continue to try to do things that are sort of at the limits of their ability. That's a good thing. can also be bad, because if they don't recognize that they don't have a skill that allows them to do something safely, like drive a car or live independently, it can be pretty challenging. So the topic of this slide is decision-making for people with Huntington's. It's not decision-making with people with Huntington's. It's not collaborative decision-making with people with Huntington's. It is making a decision for someone, which is very hard. It's hard to say, you know, you don't have insight into your disease and you don't have good judgment, therefore I'm going to take over decision-making for you. And so when that happens, it really needs to be when someone does not understand the dangerous consequences of their behavior. At that point, you kind of have a responsibility to intervene. Another time to make decisions for someone with Huntington's is when that person is overwhelmed with the work of living with Huntington's. And for you to take over a task they find, you know, kind of like there's not enough hours in the day and there's not enough energy for them to be able to cope with everything. If you took some of that off their plate, it would actually make their life a whole lot better. So that's another reason to make decisions for people with Huntington's. If you have to intervene, there's some ways to do it. So one behavioral plan that you can use, which is designed to help someone to not do something, which is a token economy system. So if you want somebody to not do a particular behavior, like you don't want them to pull out their eyebrows, then when they don't pull out their eyebrows and perhaps they do something else you've asked them to do instead, they get a reward. But when they do the behavior, they don't get the reward. Now, how most of us fail doing this is that when someone does the behavior, not only do we not give them the reward, we also give them all kinds of subtle punishments, like a big sigh or rolling your eyes or sitting down frustrated. All of those things can serve to be punishments. And certainly they're understandable, but they're confusing to the person who's trying to learn a new behavior. So when someone does the behavior you don't want them to do, you have to be completely neutral and just not give them the reward. The rewards need to be quite simple, an M&M, a Diet Coke, but they have to be immediate and consistent. And you need to understand that it's going to take time for this to work. The second thing is called a paired stimulus plan, where you pair a pleasant activity or memory with a resisted behavior. And in doing this, you sort of join in the behavior with the person in order to teach them how to put something pleasant with something unpleasant. For example, you can, if someone's resisting hygiene, you can find something from their past that is very pleasant to them, like a favorite song, and you can sing it with them while you do these unpleasant things. And again, a paired stimulus should be typically a sensory event: visual, auditory, taste, smell, etc. And if you have trouble figuring it out, this thing called the Adult Pleasant Events Schedule might give you some ideas. If none of the above has worked and you continue to have problems with a behavior that's particularly dangerous, you can remove access to that behavior. For example, you can have the car stolen or dismantled. You can take the person out and ask law enforcement to search the house to remove the weapons. You can put all medications in a lockbox and dispense medications only one day at a time, knowing that only 1 day's worth of medicine is not going to be a lethal dose. Or you can set it out so that instead of there's Monday, Tuesday, Wednesday, Thursday in your pill box, each one of those represents a different medication dose time, and that way somebody will know. You'll be able to say, see at 2 o'clock or not at 2 o'clock yet, and so there'll be something visual, something they can like wrap their hands around that'll make sense to them. So what do you do when things are going badly wrong, really badly wrong, and things are completely out of your control and out of the control of the person that you're dealing with? You can always pursue involuntary commitment to a psychiatric facility. Every state has their own laws. Some states are more rigorous and some states are less rigorous. But it's important to know that if this is a course of action you choose to pursue, that typically commitment to a psychiatric facility is not really a therapeutic intervention like it used to be. They really are designed now just to be an interim safety measure while you put together a new treatment plan or a new place to live or some change that will alter safety in the home or in the facility in which the person lives. It's really not legal to force medications. In North Carolina, for example, you can't force medicate anybody unless there are two psychiatrists that agree and that there has to be dangerous behavior. And if you're going to do it over a longer term, you actually have to go to a judge and ask them to. Now, I don't know how that rule is in other parts of the country, but the law in North Carolina was set up so that people can't just force their will on someone who doesn't choose to take medication who's not dangerous. If you have somebody that's on a medication that has a long-acting form and a person tends to perseverate about the usage of their medicine and it actually helps you to control perseveration to give that medication in a long-acting injection, there are a couple that can be done, and sometimes visiting psychiatric nurses can administer them. Guardianship is a legal proceeding in which a judge appoints a guardian for a person who's in need of special protection. That guardian can have responsibility for everything from finances to all medical decisions, can be family, friend, or a court-appointed guardian ad litem. The process itself, again, is a legal proceeding, and so it takes months to happen, and it's typically unnecessary. So after the convention, after I gave this talk at the convention, this guy cornered me afterwards walking down the hall, and he said, okay, I don't want to do any of those things. I'm done. I'm tired. I don't know. I'm fed up. What am I supposed to do now? What am I supposed to do if I can't find any empathy in my soul anymore? And which was, it was great. It was a great question for him to ask. So I would think that the issue is the lack of empathy temporary or permanent? And so it's important to get away from the situation to find out if it's temporary and to decide if it's time to make a permanent change. If you don't have empathy in your heart for the person that you care for, then you really have to find a new caregiver, and most of the time that's placement in a nursing facility or in a group home. So just to review, behaviors on the left, your toolbox on the right. A lot of times you can use these different techniques to address whatever the particular behavior is that you're having difficulty with. You can use behavioral plans with irritability. You can use behavioral plans with refusing treatment. So even though I presented them that way, you can mix and match. The best source of information that I've ever gotten about how to manage Huntington's disease is from people that have done it before. So, and I'm certain that this is the tip of the iceberg, what I've shared with you today. So please share with me any stories that you might have so that we can keep the list going. So I wish we had a treatment for Huntington's. I wish we had it more than anything else in the world, but we don't today. Today we have to do what we have to do today. So the question is, without a definitive treatment that's going to stop or reverse Huntington's, how do we find hope for today? And in what I think is that the question is, what can we do now to change the natural history of whatever Huntington's has been in your family? Family cultures, generation after generation after generation, people begin to accept that certain behaviors are typical of Huntington's. And my question is that really a family myth, or is it reality? Is it really truly an untreatable symptom of the disease? And so my question is without misinformation or depression or violence, will we have less to fear? Can we all live more peaceful lives? And can children that grow up today in Huntington's families experience a different disease than their parent did as a child? And so I guess the question is this a realistic hope? And those of us in North Carolina believe that we can do the impossible, and that together we can transform the lives of people affected by Huntington's. And so I will leave you with that positive note and take your questions.
Thank you, Mary. That was really a wonderful webinar. So much information, so many great suggestions. We are now going to be sending on to you the questions that have come in while you were presenting the webinar. For those who have joined us late, you can ask a question by typing it into the question box that appears in the on the right side of your screen, and then hit send, and we'll be able to send it on to Mary. So Mary, we do have a couple of questions, and we'll start right now.
Yeah, I'm going to read them first, if that's okay.
Yes, please do.
My family member tested positive this year. Is it useful to have an open conversation about what symptoms are occurring and how that could be impacting our life? Or is it better to their mental state, which is currently very depressed, to let them still be unaware of their symptoms? I'm afraid it could be more depressing to bring that knowledge to their attention, but also helpful too. So the one thing we didn't talk much about was the whole issue of adjustment. And the first year after a positive test is a year of great adjustment. And it's one of those grief moments where people go through denial and anger and bargaining and sadness, and then finally acceptance. And so I think that you have to get a sense of what somebody's ready to hear at this point. It's always better, I think, to face the hard things of life without depression as a secondary issue. So if depression is a big problem, then I would work hard. I'd make that your target. I would make depressive symptoms the target and go after them. And so if your family member has a really good relationship with the physician that diagnosed them, you might talk about the fact that it's a treatable problem, and that I think we can get you farther to feeling better soon, and let's go talk to them about these symptoms that you're having. So that's kind of the way I would go about handling that. Is it okay to support the desire of suicide knowing the future progression of the disease? This is my personal philosophy. I am invested in life, and I am invested in the quality of life of the people that I work with. And it's my personal view that people with Huntington's have a great deal to contribute to the rest of the world even with their symptoms. And I understand that's a philosophical issue. I think in the case of, I know that the person that asked me this question asked me the one before. I would say that it makes more sense to aggressively treat depressive symptoms in that setting, wondering if the thoughts of suicide are actually a symptom of depression, just like a runny nose is a symptom of a cold, or pain in your ear is a symptom of an earache. And I understand that there are some people that ask these kinds of questions, but at the stage of disease that your family member's at, I'm not sure exactly what stage that is, but I do know they have depression, and I do know that I have great luck with getting people better. How can you explain nice HD versus mean HD? People with Huntington's disease, part of the process of degeneration of their illness in the prefrontal lobes is that they become impulsive. And their filter, the filter between their mouth and what they say, or their mouth and what they do, their head and what they say and their head and what they do, is shortened a great deal. And there's plenty of times that all of us have unkind thoughts about people, and we just don't say them. We have a desire to do an unkind act, and we just don't do it. So I think that someone's temperament and someone's resolution with their life before they get Huntington's has a whole lot to do with how they're going to act after they have Huntington's. So I don't know if that completely answers your question. I think there are some people that tend with Huntington's to have more of an apathetic form of the illness, where they have more trouble with initiation, and then there's other people that have more difficulty with disinhibition. So I don't know if that completely answers your question, but that's the best I've got. How about a word to caregivers of an at-risk family member whose behavior may or may not be symptomatic? So what I said earlier was that irritability is thought to be the earliest symptom of Huntington's, potentially as much as 15 years before onset of motor signs. But irritability is also a symptom of frustration. It's a symptom of depression. It's a symptom of, irritability is something that we all do. Depression is something that you don't have to have Huntington's to have. There's a lot of these psychiatric symptoms of Huntington's that can be explained in a lot of different ways. And so what I would say is to focus on the symptoms that that person is having as opposed to the underlying cause of it. I think that going to get somebody's quality of life with or without a diagnosis is infinitely more important than the diagnosis itself. Everybody accepts things at their own pace. Doesn't being subservient cater to the illness? I guess what you're saying is the problem that I have here with your sentence is subservient. In other words, what you're saying, adjust your entire life for somebody else's problems. What I would say is rather than being subservient, you're being a surrogate frontal lobe. And I think that you're going to have a different tolerance for that based on your own needs. And if you are feeling like you are subservient to the disease, that it is completely controlling all of your life, and you have no life, and you're beginning to lose empathy, and your energy is getting ready to go, then I think that goes back to that one slide where I said if you're losing empathy, you're going to have to figure out a way to either prop yourself up, see if it's a temporary problem, add new help, or even more definitive treatment. But I don't think we're being subservient to the illness. I think we're actually mastering it. I think by taking over those brain functions that are missing, we actually are choosing to be in control. My sister is in assisted living now. How can we deal with smoking too much, more than she can afford? Are there any ideas to help her with this besides just letting her cigarettes run out for the month and say she can't afford more until the next month begins? Any ideas? So this is one of those behaviors where you can join in and actually what you might do is you might give her something in between cigarettes so that for every cigarette she smokes, she has to chew gum, or for every cigarette she smokes, she has to fold a washcloth, or something else that will pace out her cigarettes over time. What are the advantages of Risperdal, disadvantages? Is there a better choice for antipsychotics and OCD behavior that gets progressively worse? The whole issue of which antipsychotic and which medication to use is a very complicated one. A lot of times the prescription of antipsychotics or antidepressants are more based on side effects that you prefer as opposed to the effectiveness of the particular drugs. There's fairly similar response rates, for example, with Risperdal and Zyprexa and other drugs. For schizophrenia, for example, so you'd expect that how you measure one against the other in schizophrenia would be fairly similar for Huntington's. But again, it's not the why you might choose a particular drug has more to do with favorable side effects than anything else. And what I said early on was that having a good relationship with a physician who can talk with you about some of these peripheral issues about sleep and appetite and weight and so forth, that's a question that I would suggest you discuss with the primary neurologist or psychiatrist involved with your loved ones. What can be used for balance issues? Is Xenazine appropriate? What are pros and cons? Is there a better choice? So since we're talking about non-pharmacologic interventions, what I would suggest is that when it comes to balance, I would suggest a physical therapy evaluation. And the motor signs of Huntington's are not just chorea. They are also dystonia, which is actually kind of a more disabling movement disorder component of Huntington's than the chorea itself. And most of the antipsychotics, Haldol, Risperidol, etc., as well as Xenazine, don't treat dystonia. They just treat chorea. So what I would suggest is that you talk with a physical therapist and ask your physician for a PT referral. So that's all the questions I have.
I think that that is all the questions. We will remain on the line for another moment or two in case someone thinks of a question in these last few minutes. I do want to take this opportunity to thank Mary Edmondson for presenting this really extraordinary, wonderful webinar today. Again, people who had to leave us early or those who were unable to join us today can view this webinar in about 24 to 48 hours from today on the HDSA national website, www.hdsa.org. Again, we will be having a PowerPoint presentation accompanying this webinar, so you can print out the slides. And Mary has also provided a handout in a PDF format that provides additional information and strategies for you to use in conjunction with what she's provided today. So there are no more questions. I'd like to thank everybody very much for joining us today. And thank you, Dr. Edmondson, for once again presenting this webinar. Have a good day.
Thank you so much. You too.